So I really am honored to be amongst the wonderful speakers you've had to this journal club, and to be included amongst that club is really wonderful. And I thank you for the chance to address this audience. Some faces and names are kind and have joined us from at this time across many time zones, and I'm sure others will join us later in the online versions of this. We now have a little bit of breathing room in terms of looking into some of these rare diseases like Wilson disease, because with all the efforts of people like yourselves, hepatitis B and hepatitis C is now, starting to become under control, certainly not eradicated, but a goal for the future for the field of hepatology and infectious disease. But that gives us a little bit more bandwidth to come back to some of these rare disorders and genetic disorders that have always been there in the background. What I'm going to share with you over the next few minutes is really an update with a perspective of historical perspective, and sort of it helps you understand where all these are coming from, and hopefully leading us towards a path for cure for all these individuals. So these are my disclosures. And we're going to review the normal copper metabolism and pathophysiology of the disease, and you'll see how this will inform the action of specific therapies and why we're interested in development of certain areas where we have unmet need. We're going to talk a little bit about the natural history and the very clinical presentation and how that actually influences treatment choice. And I'll use an illustrated case for that for you. And I'm going to talk a little bit about monitoring treatment for Wilson disease. There are advances in that direction, as well as new and emerging therapies, which will hopefully bring us closer to cure in the future. The original monograph from Wilson was published back in 1911, 1912, and there is a wonderful online PDF version that can be downloaded if people want to go back and see an incredible description of a syndrome which had been around but never as well described before. And what Wilson described, and you can see on the top with the young lady in the middle before she was affected, and then patients as they would appear to the right. You can see the dystonic posture, the mouth and with dystonia, and the risus sardonicus, which was classic. And this all resulted from the neurologic damage. And unfortunately, in Wilson's day, he attended the autopsy, and this would be an example of the brain in this patient, where you would see the injury to the lenticular nucleus. But where the name hepatolenticular disease came from was Wilson was astute enough in his day to attend the autopsies of his patients and then put his hand below the diaphragm and began to recognize that the liver of these patients was affected with a nodular cirrhosis. And therefore, he postulated that the toxin that was injuring the brain was likely the same toxin injuring the liver, and he certainly was prescient. But in his day, the natural history of disease was just progression, recognition, progression to death. Now, in terms of understanding that it is the disease which bears his name, and just for one moment, there tends to be a movement now, and you'll see in a number of these slides using the name Wilson as opposed to Wilson's, because there's a movement on to name things after maybe more physiologic mechanism in terms of what they're related to. But the basic fact is Wilson didn't have the disease himself, so we tend to refer to it as Wilson, not Wilson's anymore. But be that as it may, Kinnear Wilson was an interesting man, and he ties the different continents together. He was born in the United States, but did his education over in the UK, and the work that he had done afterwards was there. But he led to findings that come to us from all over the world. Subsequently to his initial description of the syndrome, Rumpel identified the toxin that Wilson had postulated as copper. And about a decade later, there was the recognition that this disease tended to occur in a familial pattern. And this was becoming clear that it was an autosomal recessive disorder. Then came the first diagnostics, first recognition that urine copper could be elevated in symptomatic patients. And then subsequently in the 1950s, from two separate groups, Scheinberg and Gitlin up at Mass General at the time, Byrne and Kunkel at Rockefeller, came the recognition that there was a low circulating level of the protein ceruloplasmin in patients with Wilson disease. We'll come back to how that occurs. But actually, if you reflect, this was probably the first blood test for a genetic disease that had been developed. And even though the original work used octoloni plates to detect the concentration of the protein using antibody, we obviously have more sophisticated methods now. We'll touch on that a little bit later. A big advance in diagnosis came when the liver biopsy needle became available. And we have, thanks to Professor Mangini and others who developed other variations that allowed us to get percutaneous samples. And then we were able to start to incorporate histology and quantitation of the metal in the tissue as diagnostic features for the disease. And in the late 1970s and really in the 80s and 90s ushered in the molecular era, where we began to understand the molecular pathophysiology for Wilson disease once the chromosome was identified and the gene for the disorder, proving it was monogenic and that it was related to the copper metabolism, was identified separately by three different laboratories: Conrad Gilham's lab at Columbia, Diane Cox at that time, Toronto, later of Edmonton, and John Gitlin at that time was at WashU in St. Louis. And they all three came upon the same gene by slightly different methodology, but it all led back and helped us advance the understanding. And then the next advance really in diagnostics came, and a group of us got together, and I was very young at the time, but it was wonderful being amongst some of the giants in the field. And the criterion, which became known as the Leipzig criteria for the gathering in Leipzig, Germany, where this was discussed, incorporated both clinical biochemical and for the first time the molecular diagnostics for Wilson disease into a graded scoring system. While imperfect, it really gave us a guide that we still follow to this day and has proven useful when we want to establish the diagnosis very firmly and have a standardized way of talking about it across investigators. Two other advances I'll mention. The first is the relatively exchangeable copper, and the French groups believe that the ratio of the exchangeable copper, which is sort of the parallel to bioavailable copper, over the total copper gives one the ability to separate Wilson disease from other disorders. This seems to be holding up over time and needs some external validation outside of the original groups that have developed it, but maybe another advance in terms of helping us in diagnostics that in the future we could incorporate into a criteria. I'm going to tell you briefly about one other interesting finding that was published in 2021 in gastroenterology. A colleague, Si-Hoon Han from Seattle Children's, a geneticist, had been working on the ATP7B peptides that could be recovered from blood spots that were digested for peptides and then used, exposed to monoclonal antibodies that recognize specific parts of the ATP7B protein. Now, because they were taking this from red blood cell spots, it's most likely these were being derived from white blood cells in the sample. Be that as it may, they were able to separate different levels of these peptides between patients who had Wilson disease, and that is shown on the right, whose levels are lower, compared to control individuals as well. And this needs to be validated across heterozygotes, which we wonder whether they may or may not have an intermediate value in some of the patients more frequently. But this is in development now still and being validated for potential use in newborn screening, which is another exciting area in the field. Now, this is a schematic of what the gene was thought to look like. It was courtesy of John Gitlin. And what you find is this is a transmembrane protein, has a very interesting amino terminus, which has very repeat regions that are cysteine rich. And this is thought to be, and this is the cytoplasmic facing region of the protein, thought to be sensing for copper because copper will bind to these sites. But some of these could be excised from the gene and then made into message and then protein, and you would still have functional transport because the functional transporter really is an essential part of the molecule with various different sites related to the binding and energy transfer, as this is an ATPase and requires energy for the process. But this is mainly expressed in the liver cells, which is why, and I'll show you why it's so important in terms of its function. This is the normal schematic for copper metabolism in a very simplified fashion, just to highlight that we all have to import copper from our diets because it's an essential metal involved in very critical reactions, everything from cytochrome reactions to neurotransmitter production in the dopamine pathway to our cross-linking of collagen from lysyl oxidase and antioxidants from superoxide dismutase. These are all copper-containing reactions where the copper is a cofactor. So we have to replace our losses, but like most things, you don't want too much because copper is a metal which will induce oxidative injury, both to lipid membranes, proteins, as well as DNA. And so you want to fine-tune a mechanism so we have what we need for our body's reactions, not accumulate too much, nor have a deficiency, which may result in other complications as well. So the liver is really that central point because the ATP7B protein serves as a sorting, and whenever there's excess, it allows of copper, it allows excretion into the gut, and the bile that's excreted with copper does not undergo enterohepatic recirculation, so that's an exit for the excess copper. And in most normal individuals, this is an extremely efficient pathway, with the exception being patients who have prolonged cholestasis, because this is a dependence upon biliary excretion. Now, the liver is in equilibrium with what we call a non-ceruloplasmin copper. So this is the bioavailable pool that's used for extrahepatic utilization in all our tissues in the body. And there's a slight amount that the kidney sees that is then taken out and excreted. Now, the liver is also the biosynthetic site for the protein ceruloplasmin, which typically has between 6 and 7 copper atoms per molecule. And because of that, when you do have a defect in the protein for Wilson disease, you don't incorporate copper normally into that. But interestingly, you can be absent ceruloplasmin, example being the disorder where the RNA is not produced properly, known as aceruloplasminemia. And that itself actually won't affect copper excretion. So what we find is that ceruloplasmin really is more important in terms of our iron pathway because it serves as a circulating peroxidase. So in itself is not really an exchangeable protein. So what happens when the patient has a defect in ATP7B? Biliary excretion, where that pathway is controlled by that protein, to a large degree, is shut down, but the cells, it's not completely shut down. There are alternative pathways which are lower affinity but higher capacity with glutathione, where copper can get out of the liver into bile, but it's at a smaller percent than normal, and so it accumulates in the liver and leads to liver damage. Similarly, the part of the pathway where copper goes into ceruloplasmin is affected, and that turns out to be in the trans-Golgi process, where the protein is refolded with the copper in it. Now, if you have Wilson disease and you don't have that copper pump putting copper properly either in there or into bile, what happens is you produce the peptide without the copper, and we call that apoceruloplasmin. And that actually has a shorter circulating half-life than the properly folded copper protein. So that's why our levels of ceruloplasmin in the steady state are low in patients with Wilson disease. But the important piece is that the pool of non-ceruloplasmin copper expands because the liver is saturated now. You have extrahepatic copper deposition. The most famous site for this is obviously in the neurologic system, but as you saw that picture from one of Wilson's patients, what happens there. And you also now have an increased delivery of the copper to the kidney, and the urinary copper excretion goes up above baseline as well. So from a diagnostic standpoint, by understanding pathophysiology, we can understand why we have the phenotypic change in ceruloplasmin and why we look for both increased urinary copper excretion. And in the future, I'll come back to a little later, talk about the non-ceruloplasmin copper and new methodology to start looking at that. Now, in the course of untreated Wilson disease, and it's a really fascinating disorder in that you have such variability. And so this course, while I think is accurate in terms of time, we have such modification of the disease between individuals that even siblings can have very different, with the same mutation, can have very different presentations. Both gender seems to matter. Females may have a more accelerated course in some instances and have a higher frequency of developing the pathway that leads to acute liver injury and acute liver failure compared to male counterparts. But the process all sort of goes back to the liver in the beginning, and then over time, as the copper accumulates and you have further and further damage into the liver, leading to initially nonspecific symptoms, but later cirrhosis and then complications of portal hypertension. If these are unchecked, the patient will die of liver failure. Now, it's typically around the time they have advanced fibrosis or cirrhosis that they also will start developing the neuropsychiatric symptoms. So that's why it takes time for that. So typically these are in the late second, third decade of life compared to the hepatic presentations, which occur earlier. Now, about 5% of patients go down the pathway of developing acute liver failure. And it's unsure why these particular patients sort separately in terms of their presentation. Some we think may have had either drug-induced liver injury, and some may have had other viral hepatitis, which then led to injuries and reduction of antioxidant potential within the liver cells and a dropout of the liver cells and then release of copper in the circulation, which then leads to the very well described hemolysis that's typically seen. That's a non-immune hemolysis that attends with these patients with acute liver failure. For want of time, I didn't include too much about the liver failure rescues or transplant, but in these individuals, when you either have chronic liver failure or acute liver failure due to Wilson disease, transplant can be life-saving. My colleague Anil Dewan, known I'm sure to many of you, and his work at the group at King's helped define the prognostic score known as the New Wilson Index. And that is very useful to calculate, to look for patients with liver failure, either chronic or acute. And then you can see if that score is raised above 10, in those individuals, you have a higher probability you will continue to need a transplant. One of the things we talk about in the new guidance is actually using that prognostic score in a serial fashion, so that if you're seeing a patient and you think they're close to this part of the spectrum but may not have crossed the last line, sometimes as you can treat them for their Wilson disease, you will see a decrease in their score, and that may give us a little bit more hope that medical therapy may be possible for those individuals. Otherwise, they're typically destined to die if they're not transplanted. But this is, again, a smaller percent, that only about 5% have acute liver failure, and that forms about 4% of all acute liver failure worldwide anyway. Okay. Now, when should we consider Wilson disease? And, many of us will, know that our colleagues that are not as focused on liver disease may not see as many patients, but if they're come across patients with unexplained liver disease, again, we have to sort this from amongst the large pool of individuals with all different reasons for liver disease. Patients who have neurologic or psychiatric disease with abnormalities of the liver definitely have to look there. As I mentioned, those with acute liver failure. And the reason we want to sort it for them and don't just say, okay, go for your transplant no matter what anyway, we do recognize that you have the opportunity as a genetic disease to then screen other family members and primary family members, in particular siblings, have a high probability, 1 in 4, assuming the parents were each heterozygotes, of developing the same pathway. And I've seen that where patients have failed to have full family members screened, and then we've had the same tragedy occur in another family member needlessly, because they could have been found at an either earlier symptomatic or asymptomatic phase of disease and treated easily. Again, all primary family members in particular need to be considered for Wilson disease. And then we sometimes stumble on the diagnosis. People who have MRIs or CAT scans of the brain, which you get back a read from the radiologist says, consider metabolic or diseases like Wilson disease. And we have to take those signs seriously and look back and see whether their history might be matching and make sure that they're excluded. Kaiser-Fleischer rings can be found. These are the corneal deposits of copper in Descemet's membrane. And this is found in 50% with liver disease, almost universal in those with neuropsychiatric findings. But I've had patients show up to either an optometrist or ophthalmologist and asymptomatic. Otherwise, they found the rings. And then fortunately, they had people who said, go ahead and get that evaluated further. Now, a new area that many of you are going to see going forward is that patients may come to you after they've had genetic screening, either as part of these whole exome projects or various different reasons. Nervous parents often now have many of these different profiles done. And we have actually seen patients in utero diagnosed now, which poses a whole different set of problems for us. Most of us aren't working in the adult world, don't often think as much about growth and development, but that throws a whole new confounder in that we have to consider when we want to think about when to start treatment and also how to define the disease in these very young individuals. Now, another thing that's coming, we hope, whether or not it's going to be done ultimately through all the gene profiling, and that's probably a matter of computing speed and cost ultimately, or through peptide assays like Si-Hoon Han has been developing. We're not sure, but definitely will come to us. But remember, screening, even when instituted, is not 100%. So we're still going to have our antenna out there into the adult world and make sure we find these individuals. But certainly it will, in theory, find some patients at the earlier phase of the disease. They can help both with family planning as well as their own longevity is influenced by when they're started on treatment. I do refer you to our new guidance on Wilson disease, and I always have a great debt of gratitude to the Guidelines Committee for the ASLD for allowing us to expand our writing group out and include not only just pediatric and adult hepatologists, but pathologists, neurologists, psychiatrists, dietitian, and really recognizes the multidisciplinary nature of the care some of these patients benefit from. But I do refer you to it. It is we believe, a wonderful document that hopefully will continue to evolve as our practices evolve. Now, let me come back to the Leipzig score for a moment, because often people ask, how do I start to make the diagnosis? And we do have some really nice algorithms for those who are for family screening, for liver disease, and those with neuropsychiatric disease. And we go through that in the guidance. But when it comes down to it, you ultimately have the individual. And what we did in the algorithms was to incorporate the scoring system from the Leipzig score so you can use it for that individual in the algorithm as well, and helps drive you through it and understand when you're at. What these are a list of signs and symptoms, testing, and the testing, as I mentioned, includes both many of the things we think of very regularly, which is the quantity of copper in the tissue, urinary excretion of copper, the amount of ceruloplasmin. All these tests has to do with where the utility has to do with the pretest probability, and also our willingness to accept whether we want higher sensitivity to pick it up or higher specificity. So take an example for ceruloplasmin, that's why there's 2 different scores for this. When the value is very, very low, it's less likely to be the 20% crossover with heterozygotes. hits as compared to those who have an intermediate value, which is slightly low. And in those individuals, it crosses over more frequently. And so for that reason is why that receives sort of a graded scoring. But again, it's always a balance. And the same thing for the liver copper. It's a balance between sensitivity, specificity as to what value we give it. And similarly for the urine. Now, an interesting part is that, even though we don't give negative, we do give negative if you come up with normal liver copper, and that's actually the only negative subtraction on the test. But we have had individuals that have had no identified mutations. Some of this has to do with how the sequencing may be done. There may be other deeper sequencing to look for upstream regions or intronic regions, as well as the exons sequencing. So when we see individuals that don't have the mutations for Wilson's, when we do that as part of an evaluation, if we're able to do that, it's not 100%, and we have to recognize that. All right, let me bring you to a case study, a young, I won't say young lady, but a young in spirit woman that came to us recently. And again, if you start looking at the age alone, you might say, why are we looking for Wilson disease? But things will sort of, I think, make sense why we have to exclude it in this individual. So she had a history of hemangioma resections many years ago. There was nothing reported other than a hemangioma in the pathology at that time. She is a pre-diabetic, and like many in that same state, had a fatty liver, did have some chronic history of depression and anxiety, and happens to be a vegetarian as well. Amazingly, her labs showed a normal set of aminotransferases, platelet counts, and the INR. And somewhere during a rheumatologic evaluation for a low level and non-specific ANA positivity, it was found she had a low ceruloplasmin and a low matching serum copper. Now, at first they were thinking she's copper deficient, but they got back a 24-hour urine copper, and that was 42.9 micrograms. Now, the value, any value above 40 micrograms warrants further looking in terms of Wilson disease. That plus the low ceruloplasmin led them to push to the next step and do the mutation analysis. And of course, it comes back with only one mutation that's a known, and the other is one of these variants. Now, I should tell you, there's over 600 known mutations, at least 500 pathogenic, another 100 that fall into this variants of uncertain significance category. So it makes that, as I mentioned before, helpful, but not completely helpful in this case for diagnosis. Now, we have, if we calculate a Leipzig score, we had a fairly low ceruloplasmin, so we get 2, urine copper fall into the 1 category. And if we count the heterozygosity, we actually have reached a score of 4. But given she's 69, normal liver test, it doesn't seem very satisfying to me. And it would make me wonder whether we're sort of dancing on the edge of accuracy. And so we took it to the next level for her, and we started looking further into the liver. And we knew she had hemangiomas, so we had to be a little careful about where we were going to put the needles for tissue for diagnostic. So we did the ultrasound, and then our interventional people wanted to have MRI so they could see these more clearly, make sure that they were all hemangioma. And they also gave them a nice roadmap so they would go back to, and they found nice windows. So they actually got us good tissue for histology, copper quantitation, and I also want to give a shout out to ultrastructure, which is not part of the Leipzig criteria, but was one of the contributions of my mentor, Erman Sternly, was recognizing the mitochondrial changes that occurs in the early phase in untreated patients with this disease, especially those that have the fatty change, microsteatosis, which is uncommon otherwise. So what did we find? She had a mild chronic hepatitis. The portal areas had lymphocytic inflammation, but not enough plasma cells or interphase hepatitis to worry about autoimmunity. And then she had that interesting mix of large and small droplet steatosis. It's very rare there's only a handful of things that give you that microvesicular steatosis, and and that tends to be either drug reactions, things that injure the mitochondria, aka copper as well. And LAL-D is another disorder, but really there are very few. Rye syndrome has kind of gone away for the most part. Interestingly, they did the copper and iron staining, which was negative. Now, again, they got to be a little careful in the interpretation because copper can sometimes be diffused through the cytoplasm. And then so a negative stain doesn't rule out that the patient doesn't have Wilson disease. Now, we went ahead and we actually did a biopsy on her, measured the copper and weight. We took a sample for that and actually came back 800, with the cutoff typically being 250 micrograms per gram when you want to have that high sensitivity. If you want to have a higher specificity, a high specificity, if you want to have that higher sensitivity, you actually bring the cutoff down to about 75 to 100. And that was shown from nice work from, sadly, the now late Peter Ferenczi. But you can see, as well as the high copper in this patient, if you look at the mitochondria, you can see they're all enlarged. The cristae are disrupted. They're pleomorphic, different sizes and shapes. And this is a classic example of how both the copper and the ultrastructure help you with the diagnosis of Wilson disease. So now we're going to come to, we make the diagnosis, and it's always important to make it because it's potentially a lifetime of treatment. What do we treat that individual with? Well, if you go back into the day and age of Wilson, there was no treatment at all, and it was just sadly watching the patient's natural history. During the 1950s was developed the use of a compound. It was developed for other purposes, British anti-Lewisite, but that was a sulfhydryl injectable compound in oil, and that led to painful injections to patients, but it actually was the first agent that functioned as the chelating agent, increasing urinary copper excretion, and patients started getting better neurologically. Now, remember, at that time, only patients that had neurologic disease tended to be treated. Subsequently, and we owe a debt of gratitude to John Walsh, who unfortunately passed away about this past year at age 102. So he got his letter from the Queen before his passing. But he had developed both penicillamine and then later trientine for those who were intolerant to penicillamine. In a classic story, John actually was in attendance to some of the initial use of the British anti-Lewisite in Boston City Hospital. And in that setting, he recognized the power of these other, potential molecules that may chelate copper. And so he had synthesized penicillamine by a chemist, and he had to make a few grams. He took a gram himself and woke up the next morning right as rain. So he figured it's okay to give it to a patient. And lo and behold, he gave it to the patient, and urine copper went up, and thus was born the first oral treatment. Trientine, as I mentioned, he had another chemist develop when they had found that patients were developing complications from the penicillamine and they needed an alternative. In the 1970s, there was some excellent work by Schowink and colleagues coming out of the Netherlands that recognized that zinc could block copper absorption. And similar work started to go on at the University of Michigan with George Brewer, and they both ended up showing that zinc could be an effective maintenance therapy for Wilson disease. Things shifted in the mid-70s and then into the 80s because of the recognition that liver transplant could actually cure Wilson disease, but then you have transplant disease, a whole different issue for that. But the fascinating part is it did change the pathophysiology for the individuals. These individuals who were transplanted didn't need any more treatment for their Wilson disease. They now had a functional biliary copper excretion pathway. Ceruloplasmins went up to normal, assuming the donor had the normal value. And it became very, very exciting because it was kind of proof that the whole defect lay within the liver. And then when the gene was discovered and recognized to be expressed mainly in hepatocytes, it made a lot of sense then. Now, another compound was discovered, tetrathiomolybdate, worked on by George Brewer, and then later turned into through Wilson Therapeutics in a more stabilized form known as choline tetrathiamylate. Sadly, very recently, this program for development for this drug was discontinued, but I'll mention in a few moments why we were interested more so in its development. And I'll talk to you a little bit about both the gene therapy, where that's headed, and use of another trientine compound, which is a tetrahydrochloride and heat stable form of trientine, and how this is actually useful in maintenance therapy in Wilson's as well. So coming back to that schematic, how do our therapies work? Well, zinc blocks copper absorption, not directly, but indirectly by inducing this small chelating compound, metallothionein, in liver cells. And that binds initially the zinc, and then that's displaced by copper coming in from the diet and serves as a blockade. And so the biliary excretion of copper is not affected by zinc, but what happens is you have an increased amount of non-absorbed copper goes directly in the stool. So stool copper will go up with treatment with zinc. Now, when we use chelating agents, we work in a different part of the pathway. Penicillamine is very well absorbed, trientine partially absorbed, but what we're working on is this higher amount of non-ceruloplasmin copper that increases after the expansion of the liver copper pool. And you're using the chelator to pull that copper out into the urine. So over time, what you're doing, your expectation with chelation therapy is that you're pulling, at least with penicillamine trientine, is you're increasing the urine copper excretion. When you treat a patient with zinc, because you block absorption, you ultimately get a negative balance. And that's why in those individuals over time, urine copper actually goes down. All right, so when we consider the stage of the disease, when we see patients, that sort of should help us in terms of how we approach treatment. If you have an individual who's very early on and their signs and symptoms are none or few, and then those individuals, you really just are focusing on reducing inflammation, preventing new disease from progressing. And so those are patients we might consider a maintenance kind of therapy. Now, if we have symptomatic patients, and we define that a little bit more carefully now, patients who are having advancing fibrosis of significance, in those individuals, usually accompanied by inflammation as well, we think that a more aggressive and chelation therapy may be better to start with. And certainly those who have portal hypertension, we have to then approach and think about treatments that need to deal with that. If they have neuropsychiatric symptoms, again, separately, we may address that while at the same time we treat the copper problem as well. And then if we get into that liver failure category, we are looking at rescue therapies, either combinations with chelation, zinc, or other devices to try to reduce the copper, and transplant becomes the ultimate treatment there. So with our tools for this, symptomatic patients, typically penicillamine trientine, unless we're going to affect that sort of rescue mode, in which case we might try things like pheresis, albumin dialysis, MARS, and we might use chelation plus zinc therapy, acting on two different spots, ultimately thinking if they don't get better, they need transplantation. But in the patient who's asymptomatic, or people we started off as symptomatic, where we started with a higher dose of treatment, over time, they may be eligible to bring them back to a lower level of chelation therapy. Zinc doesn't actually change between that, although you do have to adjust after many years if somebody becomes a little bit more copper deficient, the dose. But these are kind of each time point has a different way to approach them. Now let's come back to our patient here. She was clinically asymptomatic. She had absolutely normal liver tests, had minimal histologic change fibrosis. If you consider she had Wilson disease for a lifetime and she's 69 years old, it's amazing. In the US, there has more complicated about what costs of medicines are for different age groups and which insurances, and that's driven separately by the states as well. So she opted to be both natural in it and wanted to try the zinc salts and also cost effective because that can be gotten very inexpensively. And so we went along and we've started her on that. And hopefully it will maintain her well. We will see. All right, so let me bring to you a concept about what we look for when we start monitoring patients. So I mentioned before that non-ceruloplasmin copper, and normally that's about 10% of the total copper in the serum, which is shown going up here. The rest actually belongs to ceruloplasmin and is non-exchange. This is in the normal state when urine copper is very low. Now, in an untreated patient with Wilson disease, this pool expands of the non-ceruloplasmin copper. That's why we have the extrahepatic problems. But still, if you look, with the exception of acute liver failure where the coppers are sky high, we look at the total serum copper. That's actually low in these individuals because the ceruloplasmin copper is low. But our goal in treating these patients is to reduce this pool of non-ceruloplasmin copper. Big question we're going to have to determine with time as we have new assays is how much to reduce it by. So just in general, when you treat with chelation, you're reducing that pool and you're sending it out in the urine. And with time, that amount that which starts high will actually start coming back down. And that helps us sort of pick our goals for therapy, for treatment in these patients. However, one of the things, as we know, is urine coppers can bounce all over the place. They are affected by how well your patient gives you a full 24-hour collection. Less often now contamination, now that most of the containers are plastic and less likely to be contaminated. In the old days with glass, they had to be acid washed. But anyway, there is a way to start looking in the blood and start getting closer to that non-ceruloplasmin copper pool. Now, the French have gone about it a different way and looked at what proteins can be chelated by EDTA because copper won't come off ceruloplasmin and from use of EDTA under normal physiologic conditions, it does not exchange. So they're trying to pull the copper off any other protein, and that's what they talk about when they talk about exchangeable copper. But there is a really neat way to look at this very, very carefully now, and this is in development and was used for a study. I'll show you that in a second as an endpoint. So you can use anion exchange to separate the proteins in your circulation. And so this is from a normal individual, and this is your peak of albumin, and this is your peak of ceruloplasmin. And if you look at both the copper in that content, obviously it's higher in the normal individual where you have more ceruloplasmin, and that's where the majority of the recovery of the copper is. In a patient with Wilson disease, you can see that peak is smaller, and the overall amount of copper total was smaller as well. And so you can recover with nearly 98, 99% recovery from the fractions of that anion exchange using ICP mass spec to accurately get the copper values. And so this is now being called non-ceruloplasmin copper or accurate non-ceruloplasmin copper. And we showed that first in the laboratory from Harrington, and second in another laboratory in England had performed this assay. And that assay actually became the endpoint for a clinical study that we published last year. And this was the first head-to-head study of penicillamine treated patients who were then offered to either stay on penicillamine or shift over to trientine. Now, time won't permit me to go into too many of the details, but I do want to point out to you, we did a run-in period for these individuals, and then we made sure they met certain criteria, and then we were allowing those that were within well-treated parameters to continue on and be randomized. And they were randomized either to stay on penicillamine or go to the trientine. Those who stayed on the penicillamine, and that was the purple line here. This is the non-ceruloplasmin copper, and you can see it stayed pretty much within a nice range. And this was the primary endpoint at 24, and at 48 weeks, it drifted even a little bit lower. The interesting part is while the non-ceruloplasmin copper measured by that accurate method stayed about the same between the groups, there was a splay and difference between the penicillamine, where urine copper stayed higher, and the trientine. where it was somewhat lower. Now, it led us to postulate that there was two different actions of the trientine, which we know is not as well absorbed as the penicillamine, that it may be acting both, which is absorbed in excreting the copper. But since it's not all absorbed, the rest of it is probably staying in the gut and blocking copper, and it had to be reasonably efficient. Otherwise, your non-ceruloplasmin copper would have risen from point of randomization instead of going down over the course of the study. And there's been some other new PET imaging done since then, which may be very interesting. It'll be hopefully released very soon and showing the action of these drugs and how they behave in vivo. Now, I just want to mention of interest, sadly, the tetrathymolybdate program was discontinued, but the reason there was so much interest in that in the first place is that about anywhere from 10 to 15% of patients started on chelation therapy if they have advanced neurologic disease at their onset will get worse in a paradoxical way despite starting treatment. And we think this is because the penicillamine, and occurs as well with triam, is sort of stirred up. It's like kicking a beehive when you start off therapy and you expand that pool of non-ceruloplasmin copper because you're pulling copper out of sites. And while it's a good chelator, it doesn't hold it as tight and it can still exchange in certain circumstances. On the other hand, storage proteins like metallothionein hold on to copper very, very tightly. And these places are hard to reach within cells. And also, there's a really other interesting property of the tetrathymolybdate. As the new kid on the block, when George Brewer put it through its paces, he recognized that there became this interesting complex of the tetrathymolybdate with albumin with copper called the tripartite complex. But the interesting thing is that became inert. So that was the interest in that compound originally, to try that in neurologic trials, because that was bound so tightly it wasn't bioavailable. But the interesting part, if you look, is what's highlighted here are the dissociation constants. And you can see penicillamine 10 to the minus 16, trientine 10 to the minus 16. Interestingly, the BAL was 10 to the minus 18, but you need 10 to the minus 19, 10 to the minus 20 to actually pull out of the storage proteins in the body. And so this shows on this slide here that the higher amount of tetrathymolybdate you use, the more copper you can actually pull out of the tissue from the metallothionein, but also separately, the more complex you would have in the circulation for those individuals as well. So it was an interesting drug. Sadly, probably won't be developed further at the moment. I hope it will be able to find a home in the future. All right, let me move on to something very new, sort of take you down through the last few minutes of sort of the emerging therapies. So gene therapy is made possible by the fact that proof of principle, one, if you replace the Wilson's gene whole, and I'd say transplant is the grossest form of gene therapy, you know that you can restore phenotype in those individuals. So if you can target the liver with the gene, that functional gene for Wilson's, you can actually reduce hepatic copper, reduce the inflammation, restore that same physiology. But how do you get it in the liver cell? Well, some of the best Trojan horses developed so far, which don't put the DNA into and integrate into the patient's DNA, where we do have to worry about oncologic risk, is the adeno-associated. It's a small, non-integrating, defective replicating virus. Problem was you also have to take your gene, make it small enough to fit in there. So they had to make microforms of the Wilson's gene, taking out parts that were not as needed for the copper pump function. And that was done in preclinical studies. I'll show you in a second. Now, when you talk about AAV gene therapy, you know, it's wonderful that the AAV hones to liver cells. It's taken up by endocytosis. And ultimately, the key is that you take the payload from that, the DNA, and you create an episomal genome, and that can reproduce and produce the gene product. Now, the other things we do have to worry about is that some of these coat from the virus can be represented, and then that could create antibodies to the virus and prevent the reability to give this again. And indeed, because some of us are exposed, in fact, probably 30 to 40% of us have been exposed to various AAVs along our lifetime. The older we are, the more likely the exposure has occurred. If you have a neutralizing antibody to this in the first place, to that particular serotype used for a study, that would be a disqualifier because you wouldn't want to bind up the virus particle before it ever got into the cell. So it does have limitations, and it also has the risk of presenting and generating more immunity to the virus later on, again, preventing re-injection. But anyway, these are the two main preclinical studies that are the basis of one by Vivet and one by Ultragenyx, two separate studies, which are looking at similar AAV constructs with the Wilson disease gene that is being infused directly into patients now. It's in the phase 2 part. And so these are just beginning. So I hope within a year or two, we will have the preliminary data that will show whether we need the right dosing and how safe this is. This is very different than working on diseases where you have no background liver disease, but you have a genetic defect in the liver and you're just replacing a gene. Here, you're working on the background of liver disease. So we are starting with treated patients, limiting the populations to non-cirrhotics, and hopefully we'll find a safe way to do it, and then we can learn whether we can expand that to other groups as well. And it's important, what we're going to learn from this may also inform future possibilities of gene repair, because you have to get it in the same way into the cells as well, into the DNA, into the nucleus to find the DNA. Now, when you do have a successful delivery of the gene, what you have is ultimately reduction of, well, you can show the reproduction of ceruloplasmin. You can have and that's shown by the amount of copper that comes up in the blood over time. And excitingly, what you can see is when you reintroduce it, you can get the copper that sort of sticks in the liver in the Wilson's disease genotype to start coming out into bile. So you're restoring biliary copper excretion. And in some of the animal studies, what they've shown is you improve the histology, reduce the hepatic copper, and you can restore that animal for its lifetime. But again, rodents live a shorter period of time, so it remains to be seen how well this will do in patients. So what is our goal of these trials? We want to be able to safely discontinue standard of care treatment and show that they can function from the transgene. We have to look at both efficacy as well as the safety and determine, are we doing better than our standard of care? Some people may say, well, why do we want to cure this? We have these nice other therapies. I can tell you many people stop, at least 40 to 50% stop therapy along the way, so that's not a good thing. In the last couple minutes, I'm going to jump into a novel agent. I just want to put it in the back of your minds because I hope this is going to come forward in the next year or two. There's some fascinating studies coming out of the laboratory of Hans Zischke using this novel agent, methanobactam, which has to be delivered intravenously or intraperitoneally to animals. But the exciting part is this animal model has the high copper and the injured mitochondria, which appear, as Hans would always like to call them, croissants, and have the dilated cristae and injury. When you give this compound methanobactam, what happens is the number of mitochondria that are injured go down, the hydrogen peroxide production goes down. Interestingly, the mitochondrial copper goes down, and the content of the copper in the liver tissue, shown here by this heat map afterwards, goes way down with the methanobactam. Now, in a more recent study just published in Gastroenterology, and it's used two different types of the methanobactams labeled here, and this is a PET scan of an animal model of Wilson disease. And what you can see is you see the copper lives here, and then with the methanobactam, the same compounds that were driving down the tissue copper, you see reappearance in the gut, and that is restoration of biliary copper excretion. And so this is the first agent that's actually recapitulated, driving things into the normal pathway. So we'll see whether this becomes another option in our armamentarium for treatment in the future. What other things are we considering? There's other novel chelators. Current chelators cannot get us in and across the blood-brain barrier. There may be other vectors other than AAV. We may find that lentivirus, which can integrate, can be used safely. There may be gene repair introduced by CRISPR, whether it's short segment, long segment, that remains to be seen. ATP7B protein augmentation may allow use of chemical chaperones for some of the mutants to move the misplaced protein around the cell. There may be oligonucleotide therapy as well. There have been some experiments done with hepatocyte transplant. Probably more exciting has been the differentiation towards hepatocyte lineage of interstitial cells, allowing an external repair and then reintroduction of treated cells ex vivo back into the patients, or in these cases, animal models initially, and that would be another area of development. And there may be other targets to reduce copper into cells if you can uniquely affect liver's copper transporters or other separate pathways which may restore injury in liver cells. Those can be alternatives as well. So what are some of the simple lessons? One, we can learn a lot from these rare disorders about what our normal physiologic pathways are. Two, consider Wilson disease in the right setting, and then do the evaluation, carry it through to the end, and then you can really help the individual and help their families. Always establish a diagnosis. Remember, that's if you don't do that carefully, you're starting people on treatment. You raise the question of whether they really have needed it, and that's not a good thing to have to revisit many years later, although we often have to do it sometimes. Choice of treatment may be phase of disease dependent, and whether they're symptomatic or asymptomatic or in the maintenance phase of treatment. I think our monitoring in the future maybe help us if we can get to that non-ceruloplasmin copper in a cost-effective way. We can use that. We might be able to get rid of our patients having to bring 24-hour urines with them to the clinics, and they may enjoy just being able to have one blood test that helps us tie it. And whether or not that represents a true biomarker for the disease process, that needs to be seen as well. Gene therapy, potentially future gene repair, all exciting and actually lead us to the potential for really a cure for this disease in the long run. And there are small areas. People that thought this disease was kind of solved, but there are still areas of unmet needs, even in this rare patient population. And I think we can then customize and use some of these newer things judiciously to help some and the others. So with that, I thank you very much for your attention, and I'm going to stop sharing and we'll open it up for questions.